Good morning, everyone, and welcome to Tyro Multidisciplinary Seminars. I first want to apologize for the fact that last week our speaker, Dr. Hugh, unfortunately had to cancel at the very last minute, which is only the second time in 3 years that we had to cancel our program on Friday morning. The good news is that she will be joining us in September to give her update talk on medullary thyroid cancer, which I was very much looking forward to, and am still very much looking forward to. So we promise to revisit the topic, and she will be presenting, as I mentioned, in September. Well, I am truly honored to have two individuals presenting this morning. It's a pleasure to introduce Dr. Jeff Rastatter, who is an associate professor of the Ann and Robert Lurie Children's Hospital of Chicago and the Department of Otolaryngology, Head and Neck Surgery at the Feinberg School of Medicine of Northwestern University. In addition to his fellowship training in pediatric otolaryngology, he has also completed a master's degree in health services and outcomes research. And we have a discussant this morning who is not a stranger to the Tyro platform. Dr. Andrew Bauer is pediatric endocrinologist, as well as the director of the Thyroid Center at the Children's Hospital of Pennsylvania. He has an extensive research interests that include the use of molecular information to guide the diagnosis and management of children with thyroid nodules and thyroid cancer. In addition to his many contributions to the literature, he currently serves as co-chair of the ATA Pediatric Thyroid Nodule and Cancer Guidelines Committee, which Dr. Rastatter is also a member of. And I am sure that the discussion this morning will migrate to talk about the latest or the updates related to those guidelines, which I just learned are due out in early 2024. Dr. Bauer is a member of the board of Tyro, and we anticipate that those updated pediatric guidelines will be put onto the platform as soon as they are completed. And so with that, I'm going to turn over the program to Dr. Rastatter. And as always, I welcome everyone to send in their questions, which I will do my best to get to before the end of the hour. So Jeff, why don't you get started, and thank you for carving out the time this morning.
All right. Well, thank you, Dr. Erkin and everyone for inviting me. First of all, well, disclosure, I have no financial interests or just anything to disclose there. I also can mention that I've presented several times with Dr. Bauer, and one thing I've learned over the years presenting with Dr. Bauer is that the best way to get a good presentation is just to get through my part as quick as possible to get Dr. Bauer talking, because he's always got so many interesting things to say and such great perspective on all of these topics. So I'm looking forward to hearing what his thoughts are on this trend we're seeing with hemithyroidectomy. But to just back up to the title slide here, the title of this paper, the 2015 American Thyroid Association Guidelines and Trends in Hemithyroidectomy Utilization for Pediatric Thyroid Cancer. So I was working with my team here, and this paper came up for a couple of reasons. One is, even as far back as a few years ago, when the ATA meeting was in Canada, I believe it was about 3 or 4 years ago. Even then, we had some roundtables, and we had some discussions, and some really interesting and robust discussions about what is the role of hemithyroidectomy in pediatric differentiated thyroid cancer. And as is often the case, we were just starting to hear more and more about hemithyroidectomy being used for some adult tumors. So you start wondering, well, what is the role of that in pediatrics? And while we don't necessarily have the full answer for that yet, I think that this study was just an attempt to say, well, let's just look at what's going on and just see if we can identify just what are the trends with use of hemithyroidectomy and differentiated thyroid tumors in kids. And really this came out of also in 2015 when we had the first dedicated pediatric guidelines for management of pediatric thyroid nodules and differentiated thyroid cancers, of which Dr. Bauer was a major contributor to that document. Is we were wondering, well, is there sort of a change, and it doesn't have any association with when those guidelines came out. It's an interesting question to ask too, because then you could say, well, do those 2015 guidelines for pediatric management of thyroid nodules advocate for hemithyroidectomy for pediatric differentiated thyroid cancers? And the answer to that is not really at that time. So the recommendation 1 in the pediatric 2015 guidelines basically just says that total thyroidectomy should be used for the majority of pediatric differentiated thyroid cancers. Now, as is often the case with guidelines, there's some room for room for discussion with that statement. It's certainly not definitive to say absolutely you should use total thyroidectomy for differentiated thyroid cancer in pediatrics, but it's certainly a stronger statement than in the adult 2015 guidelines, which went further to advocate more for discussing the equivalency of hemithyroidectomy and total thyroidectomy for some low-grade adult tumors, meaning 1 to 4 centimeters, positive, good features, contained within the thyroid gland, no evidence of spread to lymph nodes, and so on. Those adult guidelines actually advocated for that, and just was looking at this earlier today, and then just right here, that subsequent study by Ullman found that the rate in adults, you can see here in the yellow, increased from 17.3% to 22%. So in the adult world, let's see how I can get back to that other screen now. 1 second. There we go. In the adult population, that around the time that their guidelines came out advocating more for hemithyroidectomy, there was a bit of an increase. Now we all know too that a lot of physicians that take care of kids also take care of adults, and certainly folks that read the pediatric guidelines oftentimes read the adult guidelines as well. So as those come out, are we seeing a similar trend in pediatrics of increased use and comfort level with using hemithyroidectomy in pediatrics? So that was sort of the genesis for this this paper. Let's just take an observational look at it, see what's going on, and if we see something there, it'll give us some understanding of what's been going on. Then we can start to look at maybe why are the things we're seeing going on, but also just assess folks' comfort level with potentially using hemithyroidectomy for some differentiated thyroid tumors in kids. Okay, so that's sort of the background there. Again, no statements. This is just what I was just kind of discussing there. Are we seeing a change, and can we say, is that change, if we see one, have any sort of association with the release of the 2015 guidelines looking at making recommendations and expert opinion on pediatric tumors. So just briefly with the methodology, we utilized the National Cancer Database for this. We used the participant user file up through 2018. At the time we started working on this paper, that was the newest version. There is a newer version now. I suspect folks probably have familiarity with this database, but in case you don't, it is a very large and robust database that is jointly managed by the American Cancer Society, also the Commission on Cancer, the American College of Surgeons. It's a US-based national data set which captures 72% or so of newly diagnosed malignancies in the US annually, and the thyroid cancer capture rate is actually a little bit higher than that even. And it's a very well-maintained database. It has a lot of good variables for doing research, different than some other databases. It's actually maintained and designed for research, as opposed to just trying to use databases that are perhaps for billing or other reasons, just using them for database. It is designed for research, so it has some really nice variables. So ultimately, we were able to identify close to 5,000 patients that were pediatric, 18 years old or younger with differentiated thyroid cancer. And we did several things on this. We did some univariate analysis looking at at factors associated with whether kids were treated with hemithyroidectomy versus total thyroidectomy. And then using that information, we did some multivariate logistic analysis, and then also did some causal impact time series analysis. And I'll show you the results for that causal impact, but briefly, what causal impact time series analysis is it's a way of looking at associated factors when you don't really have an ability to truly randomize the participants. So it looks at what should the incidence, it tries to look at what should the incidence of something, whatever you're looking at, in this case, hemithyroidectomy, be. What would you anticipate it being just in general moving forward? And at the time of some incident, in this case, the release of the 2015 pediatric guidelines, do we see an actual rate of hemithyroidectomy that is different than what is expected, and can we quantify that? So that's what causal impact and time series analysis does. So our study population was from 2007 to 2018, and initially identified just over 5,000 patients with differentiated thyroid cancer, with limitations with any study, and certainly with like using these national data sets. I think it's important to have proper exclusion criteria, and patients that had documentation of resection of less than a lobe, or it just wasn't known exactly what surgery they had, certainly we had to exclude those. But we were still left with 4,776 patients pediatric patients who did have our surgical resection of interest, being we had information of total thyroidectomy versus hemithyroidectomy for those. So 451 of those patients were treated with hemithyroidectomy, and the rest with total thyroidectomy. So with our univariate analysis, just get right into the results, look at what we saw, and then we can have some discussion with Dr. Bauer, and certainly hopefully others from the viewership with questions to get some good discussion going. So on univariate analysis here, looking at factors associated with who was treated with hemithyroidectomy, on univariate analysis, there was an association, a significant association, if we use the p-value of less than 0.05 as our level of significance, with race, And then going to the next slide here. And then also tumor size greater than 1 centimeter had a lower than 1 odds ratio. So if you had tumor size greater than 1 in pediatrics, you were less likely to have been treated with hemithyroidectomy. And that was similar with patients who had nodes examined or positive nodes. The National Cancer Database tries to provide information in different ways to really get at questions. So I like that they have they have data in there showing if you have positive nodes, but they also show if the nodes were even examined. So there's some patients where the nodes were just never examined. So we get some information there about nodes examined, positive nodes, distant metastases. Also, papillary histology was associated with a lower likelihood of having been treated with hemithyroidectomy. So follicular and Hürthle cell histology more likely to than papillary to be treated with hemithyroidectomy. So again, race, tumor size less than 1 centimeter, absence of nodes examined or positive nodes, and follicular or Hürthle cell pathology, all on univariate analysis associated with increased likelihood of having been treated with hemithyroidectomy. So when we took variables that on univariate analysis were significant, at least to a 0.2 level, so not to 0.05, but were suggestive of having a meaningful contribution to a multivariate regression, those factors were then included in a multivariate regression to be able to account for other variables and then see if some of these trends that we're seeing on univariate analysis were maintained on multivariate. Race dropped out as being significant in our model. Income rose in significance. So patients that have documentation of a median income higher than 50,000-ish per year were more likely to have been treated with hemithyroidectomy compared to patients of lower income brackets. And I think that's interesting. We can, in the discussion, talk about why that might be, if that's real and why that might be, but that's one thing we saw. And then tumor size maintained its significance. Histology maintained its significance, and as did nodes examined and positive nodes. So let's look at some trends. This is a figure from the results in the paper, just looking at years of surgery and patients that were treated with hemithyroidectomy versus total thyroidectomy. So you can see that the general sort of trend in general is just that the numbers are getting higher. So there's more patients being either operated on or perhaps just being captured by the National Cancer Database. But regardless, over the years, we're getting more robust collection of data on these patients. But if you look at it here, the two bars, so if we just take a look at 2007 on the left side of the table here, of the patients in 2007 that have information in the National Cancer Database, 271 with differentiated thyroid cancer in kids were treated with total thyroidectomy, and 29 were treated with a hemithyroidectomy, representing about 9.7%. And then as you just look going from left to right, percentage of patients treated with hemithyroidectomy, 9.7%, 7.3, 6.1, 10.1, 7.3, 8.4, 6.7. As we kind of get closer to 2015, we see 10.5%, 9%, 15.9% and 12%. So just as at a glance, looks like, you know, the numbers perhaps we're going up as we get toward the right side of that table. Is that significant? So that's where this causal impact analysis comes in. So here the solid black line is the actual rate of hemithyroidectomy performed during this time period of 2007 to 2018. The dotted line is what was predicted based upon the analysis if that event we looked at in 2015, again, that event being the publication of the pediatric guidelines. If that event didn't happen, we would anticipate, based on this analysis, rates of hemithyroidectomy to follow along this dotted line here. What we actually see is that in 2015, you know, this dotted line here, that the black line, the actual rate of hemithyroidectomy increased outside of 95% confidence intervals of what would be predicted based upon the analysis. So it does show that there has been an increase in use of hemithyroidectomy if we use 2015 as a time point to look, you know, before and after. So I think that is where we're at in this paper. And then really, I think a lot of the interesting part comes with what does this mean? And what are we seeing here? And I think it's interesting it's interesting in the context of what we're trying to figure out in terms of when is hemithyroidectomy appropriate for kids with differentiated thyroid cancer. This paper certainly doesn't answer that. It just shows that it seems that treating physicians are utilizing hemithyroidectomy more in pediatric differentiated thyroid cancer. We know that there was a big event in 2015 and that those guidelines were published. So perhaps, maybe they have had some role in physicians deciding to or feel comfortable with performing hemithyroidectomy for differentiated thyroid cancer in kids. It certainly doesn't prove that specific event and that event alone is leading to this increase. There are certainly are several other factors, and these possibilities lead to the very interesting conversations that we have about it. But I want to transition over here to Dr. Bauer in just a moment, but just close by this section by saying that ultimately I think that an important part of this paper is it just shows a willingness of physicians to treat patients with hemithyroidectomy, pediatric patients with differentiated thyroid cancer, in what appears to be increasing a rate of doing it. So if the comfort level is there, it behooves us to really try and understand when is it appropriate. Given that the reason that the 2015 guidelines, one of the reasons, the main reason I think that the 2015 guidelines for kids versus adults were less strongly advocating for hemithyroidectomy is due to the higher incidence of bilateral and multifocal disease with pediatric tumors compared to adults. But be that as it may, when is it appropriate in kids? That's for us all to figure out. So I'll turn it over to Dr. Bauer now.
All right. Good morning, everybody, and thank you for this opportunity. So what I hope to do now is take what Jeff's paper, which was excellent and I think a nice contribution to our literature. So congratulations, Jeff, to you and your group for pulling that together, and try to look at where the 2015 guidelines maybe succeeded. As Jeff suggested, we can't prove that, But the data supports that there was hopefully some benefit for the effort the entire committee put into authoring the guidelines, and to encourage our current committee that guidelines can make a difference. But the first version is a first attempt, and it does two things. Hopefully, one, alter practice, but also encourage research to try to figure out ways to improve what we're doing and what we've done. So I think the goal for all of us is to find opportunities to save healthy thyroid tissue, to reduce surgical and medical complications, and still achieve remission for our patients with thyroid cancer. So that's what I hope to go through in the next 10 or 15 minutes or so. These are my disclosures. None of them will impact, I think, my talk, except the last one is similar to Jeff. I'm on the committee coming up, working on the second version of our guidelines, and we have not achieved consensus. So a lot of this is my opinion, but hopefully some of it will end up in our second version of our guidelines. So again, Jeff's and his group's paper, I think, is encouraging and did show an increased risk of lobectomy from about 8% to about 12.4%. And if we look at the numbers again that Jeff just presented and put it in the context of what our 2015 guidelines suggested, there is some reason to believe that there is a change in practice. So this is the figure from our 2015 guidelines. It talks about if you have a nodule, if you undergo FNA, and then the results of the FNA that ultimately, as you can see in the highlighted box, the red highlighted box, leads to surgery. If we break that down and just take that section that is an FNA that has indeterminate cytology or suspicious, so that'd be a Bethesda category 3, 4, or 5, the guidelines say that surgery could be, lobectomy would be a reasonable choice in most cases. And to consider total thyroidectomy for nodules with Bethesda category 5. And one of the shortfalls of the guidelines is that we didn't give enough specifics because at the time we didn't have as much data. And since that time, I think we've accumulated more data to help further guide what to do with Bethesda category 5, and also how to incorporate molecular testing and other histopath features into even deciding on completion thyroidectomy for patients that undergo lobectomy with Bethesda category 3 and 4. But the portion of the guidelines that actually we were referring to as far as lobectomy aligns with the data that Jeff found in his analysis. And so it was really the follicular thyroid cancer section of the 2015 guidelines that suggested that lobectomy may be adequate to achieve remission if the tumor was less than or equal to 4 centimeters, and there were less than 4 or 5 vessels, peri-intracapsular vessels that were involved. And so this is the recommendation, 32B from the 2015 guidelines, and then as you can read there, lobectomy rather than total thyroidectomy. Since that time, there has been a change in the definition of invasive follicular thyroid cancer. So the World Health Organization now, the 5th edition, defines follicular thyroid cancer into minimally invasive, which only refers to capsular invasion. And if you have any blood vessels that are involved in the capsule or around the capsule, then it's called angioinvasive follicular thyroid cancer. Whether that alters what we should do as far as lobectomy or thinking about completion thyroidectomy, I think the data still suggests, and this is mostly adult data because we have very limited data in follicular thyroid cancer in pediatrics. But a couple of things from recent studies, and I just list 2 here, that size is probably less important, less informative as far as the risk of distant metastasis. And as the World Health Organization committee suggested, it's really about the vascular invasion. So for follicular thyroid cancer, it depends on how many vessels are involved. And you can see 2 studies in the bottom left of the screen. One study suggesting if you have more than 1 foci of angioinvasive disease, that's associated with a lower disease-specific disease-free survival. And that's a paper from 2022, just last year. And another paper from this year that looks at risk of distant metastasis. If you have less than 4 foci of angioinvasion, the risk of distant metastasis is quite low. So from the adult perspective, even with the World Health Organization changing the definition, which hopefully actually improves the care and reduces the urge to go to completion just for capsular invasion, the data for angioinvasion, I think, has been relatively stable. The more vessels involved, the more risk for distant metastasis. And then that's when we should consider doing completion so we can do a radioactive iodine whole body scan. In pediatrics, as I just suggested, the number of vessels that are involved or increase the risk of distant metastasis is not really defined. And so this is an area that would benefit from multi-center studies, and we pulled together an International Child and Adolescent Thyroid Consortium that hopefully can help provide some data within this context. The other issue for follicular thyroid cancer is if and when it does present, if someone really is at risk, oftentimes we don't know for 5 to 10 years. So many studies look at 5-year disease-free survival, but for follicular thyroid cancer and even for papillary thyroid cancer, that 1-year mark is important. The 5-year mark is somewhat informative, but really we need to look at longer-term data to figure out what the risk is for patients that may present later because of slow-growing tumors. As far as oncocytic cell carcinoma, or formerly Hürthle cell carcinoma, there's really no data in pediatrics. The one study that you can see on this slide from 2020 looked at 6 patients, pediatric patients with oncocytic cell carcinoma, suggested that it's a lower risk for distant metastasis. I know from my own anecdotal experience of the half dozen or so patients we have with oncocytic cell carcinoma, at least 50% of them have distant metastasis to bone. So I think the data is still anecdotal, but I don't, at least in my practice, have any reason to think patients with oncocytic cell carcinoma are at a lower risk for distant metastasis. I think they're at the same, if not higher. And again, it comes back to angioinvasion in the capsule to help predict that. And so that's another area of active research where there's really a paucity of data within the pediatric population. As far as papillary thyroid cancer, that's the part of the guidelines that we really, I think, need to focus on and to look for opportunities, because that's the portion that, as Jeff summarized, that suggested that most patients, this is recommendation 11, that have Bethesda 6 cytology should be considered for total thyroidectomy. And where we came up from that recommendation was based on things that Jeff mentioned, mostly the bilateral disease, and the numbers have really stood over time, whether, if you have a unifocal disease or if you have multifocal disease, what's the risk of having bilateral disease? And that number is really around 30 to 46%. And that's just a comparative number. You have tumor on one side for papillary thyroid cancer. Is it possible to have it on the other side? Can you see it preoperatively on ultrasound, or is it discovered postoperatively, just microscopically? The other portions of pediatric thyroid cancer are important, but we're not going to really talk that much about. The second one I will discuss a little bit, and that's the regional metastasis. So we know patients, pediatric patients with papillary thyroid cancer, depending on the type, will have at least a 60% chance of having central node metastasis. What that impacts as far as disease-free survival is still something that needs to be looked at prospectively. We have some retrospective data. And what it has to do with disease-specific mortality, thankfully, is not really relevant because 99% of our patients survive. So what we think about in pediatrics is really disease-free survival and complications of therapy. And so the risk of bilateral disease, this is a paper from our group in 2020, is brought up as, the top of that, and Jeff brought it up as well, as multifocal disease. And can you see it on ultrasound or histopath? And I think there's 2 nice papers, one from the Memorial Group just published and one from 2019, that looks at not just what's the likelihood of having bilateral disease, but what's the impact as far as clinical behavior and the risk for persistent or recurrent disease. So this first paper looked at 90 patients, pediatric patients with multifocal disease. They had 5-year outcome data, which for papillary thyroid cancer, I think is a little bit more informative than for follicular thyroid cancer. Their inclusion criteria limited patients to not have aggressive, is what they termed it, PTC variants, which would include tall cell, hobnail. They did not go on to list infiltrative forms such as widely invasive follicular or diffuse sclerosing variant, but they tried to limit it to, I think, mostly classic PTC. Tumors had to be less than 4 centimeters, and then on histopath, after lobectomy, no evidence of extrathyroidal extension, lymphatic or vascular invasion, and preoperatively, no ultrasound evidence of central or lateral neck disease. And what they found as far as outcomes is that multifocal disease didn't really impact a lower disease-free survival as long as you selected the patients with papillary thyroid cancer that might benefit, that might achieve remission just after lobectomy. They, I think, fairly questioned the 2015 pediatric guidelines, as you can see there, and those points are very well received. I mean, we ask ourselves the same questions when we publish guidelines. You know, we hope to improve care and not to have negative outcomes of care, which would include potentially increased complications. The Memorial Sloan group had a large comparative group with adults, had a large comparative group for unifocal disease in pediatrics, and had about 16 patients, pediatric patients that had multifocal disease, also had 5-year outcome data, and also showed that there was no increased rate of contralateral persistent recurrent disease defined by radiologic imaging at the 5-year mark if a pediatric patient with papillary thyroid cancer underwent lobectomy and just had multifocal disease. So I think these two are nice data, not just about the rate of bilateral disease, but also looking at what's the impact of bilateral disease as far as achieving remission. So if we again go back to papillary thyroid cancer and say, well, what if we perform lobectomy, what does predict the risk of persistent disease? So multifocal disease I put in gray because there's at least data now that suggests that may not be as impactful as we once thought. And then what about size, extrathyroidal extension, lymphatic invasion, vascular invasion, N1 disease, and extranodal extension? I think those are the factors that play out. Many of them are interrelated. Many of them can be predicted based on ultrasound features of nodules, combined with somatic oncogene data, plus minus prophylactic central neck dissection. And that's some of the things I'll talk about to close out this section. So if we go back to the part where that we have to work on, if we're really interested in finding another group of patients, not just follicular thyroid cancer patients, but patients with papillary thyroid cancer that might achieve remission with lobectomy, this is the part that we need to work on and hopefully have as a discussion and add to the version 2 of our guidelines. So what could help predict these factors pre and post-operatively? We all know in practice, and we all know from adult data, that there are certain papillary thyroid cancers that just have lower invasive behavior. The one that is most common as far as what we see in practice is the minimally invasive encapsulated follicular variant of papillary thyroid cancer. And there's 2 studies in pediatrics, one from Jonathan Wasserman's group in sick kids, one from our group, now a couple of years old, that show that if you pursue lobectomy, and in both of these papers, we had patients that had total thyroidectomy. So this is not a prospective, it's a retrospective study looking at the data. Could we have achieved remission with lobectomy? And it's informative, although the prospective piece needs to be performed, but no history of radiation or tumor predisposition. And that's actually open for discussion as far as do all patients with P10 or Dicer-1 syndrome benefit from total thyroidectomy up front, but no history of radiation, N0B disease, so not clinically evident on preoperative ultrasound, or if they had prophylactic central neck dissection, less than 5 lymph nodes, microscopic lymph nodes detected on pathology, no lymphatic or vascular invasion, no extrathyroidal extension. Those patients could have achieved remission based on our data if they had undergone lobectomy. For classic PTC, I think we need to think about other features and to think about mostly about the central neck and the somatic oncogenes to help predict if someone could achieve remission or not. The nicest paper, the most robust paper to date is now from 2020 from Sagino. Then they looked at 153 patients under 19 years of age, 76% had lobectomy, and they were performing ipsilateral prophylactic central neck dissection, as you can see there, for all patients over the preceding since 2000 as far as their data analysis. What they showed was that 22% of their patients had recurrence, but if they subdivided those patients and looked at low risk, and they defined low risk as no clinical preoperative evidence, so N0B disease, no extrathyroidal extension on surgical path, and lymph node disease limited to less than 10 lymph nodes on postoperative histopath exam, microscopic, then the risk of recurrence after lobectomy was much lower, from 22% down to less than 7%, 6.7%, and 10-year disease-free survival, 92%. So again, a little bit different, I think, as far as how we think about patients that we might consider for lobectomy, even with a Bethesda 6 cytopath preoperatively. Our group went back and looked at patients, again, with small tumors, which Jeff's paper, I think, brought up as well. Does the size of the tumor impact the likelihood of bilateral disease? And we found is patients that had T1A disease, less than a centimeter, less than or equal to a centimeter, which was 52 patients, unifocal PTC, and no clinical evidence, N0B, and less than 4 positive lymph nodes on prophylactic central neck. There was very low risk for bilateral disease, and supporting the Sagina data that lobectomy would have been adequate to achieve remission. If the tumor size was a little bit bigger, an N1B tumor, and multifocality, at least in our retrospective review, was associated with increased risk of bilateral disease, but we did not look at outcome, which is a criticism from the Memorial Sloan group, which I think is, again, an important criticism. We need to look at outcome to really understand impact. So prophylactic central neck dissection, I know it's controversial in pediatrics, and we have different camps, even on our ATA guidelines, but we think about it in pediatric differently. It's used to assess invasive behavior. It's just another piece of data, and it comes down to risk benefit. And so there really is no risk if we could obtain data that would make us more comfortable with lobectomy as far as permanent hypoparathyroidism, because if we have the data that the lobectomy with the central neck, and less than 4 or 10, it depends what data you believe on, microscopic lymph nodes that were positive, then we don't have to go back to the OR, and we can follow those patients as far as surveillance. So I never would have considered lobectomy with an ipsilateral central neck at the time we wrote the first version of our guidelines, but I think it is something that's up for discussion. We also have a little bit more information, and this is now initially suggested, our ATA risk levels, which defines the risk of persistent disease after initial surgery. So first, from the South Korea group in 2018, they defined intermediate risk versus low risk as far as persistent disease as less than or equal to 5 lymph nodes, kind of going along with our retrospective data. And so the number of lymph nodes, if it's performed, can help predict the likelihood of persistent disease. But multifocality, I think, to the Memorial group and the group from 2019 may not be as an important criteria as we initially suggested in our first guidelines. And now in 2023, there's another paper that has came out in Frontiers in Oncology that suggests, again, outcome, not just incidence or rate, that prophylactic central neck dissection can be associated with reduced disease-free survival and pediatric PTC. So I don't have the right answer. I'm not going to claim that every patient benefits from it, but I think collecting the data to help define, especially for a 10-year-old, a 15-year-old, what's the likelihood that we achieve remission is an important question, because yes, I absolutely agree, we can salvage patients if they have recurrence at 3 years, 5 years, 10 years by disease that's in the contralateral lobe or in a lymph node. Yes, they'll go back to the OR and they will still have excellent outcome. That's not the discussion. The discussion is, can we achieve it after the initial therapy as far as remission? To close things out, to leave things time for questions, is how do oncogenes play a factor? I'm not going to belabor this, but there are oncogenes, and the Cancer Genome Atlas established it, and many other papers that are associated with low invasive versus high invasive disease. And it's true in pediatrics as well as in adults. That the Cancer Genome Atlas didn't really look at adult patients with distant mets, but there's now some papers that look at that. And the pediatric patients, we've all looked at this pretty extensively now, and you can see the list of articles that have come out that help define BRAF E600E and fusions as an increased risk of regional and distant metastasis. The World Health Organization, as part of the committee writing the section on PTC, allowed, and the committee agreed to include, how could we incorporate oncogenes into the surgical approach? And you can see from this table, which is now published, that low invasive somatic alterations that are known preoperatively can help dictate whether lobectomy has a high likelihood of achieving remission. And so this is where we are, I think, in 2023, is it's all about stratification of care, whether we can surveil, not even perform an FNA, or whether patients need an FNA total thyroidectomy and whatever degree of lymph node dissection, plus radioactive iodine to achieve remission. Lobectomy is on this spectrum. I think ultrasound features are really, really informative as far as predicting who will have central neck disease or lateral neck disease. Cytology clearly is important, and I think somatic oncogene analysis is important. And then post-operatively after lobectomy, looking at the histologic features, maybe not multifocality, but lymphatic, vascular invasion, all the other things that we talked about. And I absolutely believe that prophylactic central neck provides additional data to have a higher comfort level about achieving remission after initial surgery. Jeff's data on who is achieving lobectomy based on income, I think, is troubling but not unique. I think this is true for many people in our country as far as access to healthcare, and something that we can't ignore and need to try to address. But that's a big public health issue, but an important one. But we also have to throw the patients in here. And when we think about lobectomy, they have to undergo radiologic surveillance. Thyroglobulin becomes a less specific marker for persistent or recurrent disease. And then we need to help define how long do they have to undergo surveillance for, 1 year, 5 years, 10 years, 20 years, if they're not on thyroid hormone replacement, so they're not getting labs every year, so they're not getting a thyroglobulin every year. And so for follicular, it may be at least 10 years that we need surveillance. For papillary thyroid cancer, we need a discussion to figure out how long these patients had to be surveilled for. And that is an important part of encouraging patients and providers that lobectomy is a reasonable approach to achieving remission. So with that, I'll end, and hopefully we have time for questions. Hopefully there are questions, and thanks for your attention.
Well, thank you very much, Andy, much appreciated here. And Jeff, outstanding talk. Let me start with Jeff. Do you want to comment on any of Andy's discussion before I ask for any of my questions here?
No, I guess just one quick comment on the income. It is an interesting data point, but is it possible that that folks with lower income, there's some physician concern with follow-up and access to care, so they're more likely to be a little bit more aggressive and do total upfront versus feel comfortable doing hemithyroidectomy. It's certainly just speculation, but it's something we should be thoughtful of to make sure we're doing optimal care and preserving tissue when possible for all patients.
Yeah, I was struck by that, Jeff. I kind of constructed an argument in my own mind that if access to healthcare then was a driver in the decision making, that maybe one could argue that doing a hemithyroidectomy would have been a more thoughtful approach to that. So the need for either thyroid supplementation or for routine labs, et cetera. I'm not sure how I would sort of factor that into the equation. And I can't imagine that guidelines would address that issue from a recommendation point of view. Would you see that entering into the discussion here?
Yeah, no, I mean, I agree with you. It's hard to make. It would be hard to make a recommendation in a guideline, based upon that. I mean, it's certainly something we all, it's a reality of access to healthcare is reality. So we have to think about it on some level. I think it's just important that we're thinking about it in constructive ways. But it's interesting. I was thinking of it more in terms of the risk of recurrence with poor access to healthcare. Maybe you'd be a little bit more aggressive up front. But then you were looking at it less from the recurrence standpoint and more from the the increased need for medical observation if you've had a total compared to a hemi with the more likely with needing to have the thyroid hormone replacement, potentially some calcium issues and so on. So it's interesting, just depending on your perspective, there's things that could lead you in either direction. I suppose maybe the answer is just to try and address the access to healthcare issues rather than decide based upon it. If we could help people get access to healthcare, it would be less of an issue on either side.
Okay, we have a question from the audience related to whether there's any literature on the rate of completion thyroidectomy in pediatric population here. Either Andy or Jeff.
I can just say, at least from my study that we went over today, in the National Cancer Database, what's listed as their intervention is the most complete procedure or intervention that was done in their first phase of treatment. So if a completion thyroidectomy was done in the first phases of treatment, meaning you had a hemithyroidectomy, it came back positive, and you went back for a completion thyroidectomy all in reasonable time frame of each other, those get logged as a total thyroidectomy. So the granularity of knowing who got completion thyroidectomy is lacking in the National Cancer Database.
So Dr. Wasserman has sent in a comment related to the NCDB, that it only captures malignancies, and perhaps there was an increase in the overall rate of diagnostic lobectomy, with many turning out to be benign, but a higher rate of lobectomy for malignancy being an inevitable subset. I think I captured that comment correctly here. Do either of you have any thoughts related to that?
Andy, any thoughts on?
I mean, I didn't pull the data, Jeff. Is it just thyroid surgery, or that's what you were looking at, right? Not just malignancies of the 4,000 that you initially started?
Oh, well, it's so to what Jonathan was saying, it's just the nature of the National Cancer Database. It's only cancer patients. So it doesn't have any information on folks who had thyroid surgery, be it hemi or total, for something that was known or turned out to be benign. So it's just the with all of these studies, I feel like the more experience I get with studies, both evaluating them and writing them, the more robust my limitations section gets. And there's always challenges with these studies, and that's certainly a big one when you're just looking at thyroid surgery in general. You'd want to capture all patients who had thyroid surgery, not just the malignancy ones. So we have to take the results with that in mind, but still, I do think there are some interesting. It is an interesting trend, seeing the higher percentage of hemithyroidectomies in the cancer patients specifically.
So I have to be honest, the concept of prophylactic central neck is making my head spin. We have gone around the horn, and just when I think the idea of doing prophylactic central neck has disappeared from our thoughts here, it seems like it's reemerging yet again. And this is actually harkens back to a previous journal club, that this appears to be part of the strategy amongst Japanese surgeons, even in the adult population here. Maybe you can comment on that. It feels like we are just running in circles here, and I'm wondering if your worries regarding, certainly from a staging perspective, and certainly from the point of view that you're not increasing the risk of hypoparathyroidism, I got to believe that depending on the skill sets, you're going to put the recurrent laryngeal nerve at increased risk if you were doing a more comprehensive clean out on the side of the lobectomy. Maybe you can just comment on that.
Well, I can certainly, comment from a surgical perspective. I think, first of all, just say to what Dr. Bauer was saying about the information can be helpful. I would agree with that. It is nice to have that information. On the other hand, there is no such thing as risk-free surgery. There's always some risk. When Dr. Bauer and I and others in our groups that oftentimes meet and talk together and so on have talked about this, one of the things that always comes up is, what do you mean by a central neck? And to Dr. Erkin, what you were just sort of suggesting there too, that if you do a really good clean out, you certainly put the nerve at more risk than if you're just kind of taking some nodes in the central neck. I mean, when we look at a lot of these databases, or you look at operative reports and so on, a lot of times it'll just say like a central neck dissection was done or it wasn't. And so in my hands, oftentimes, if I have a really low risk thyroid tumor, oftentimes I'll do what I call like a mini central neck, where I'll just take some of the pretracheal lymph nodes, which are extremely low risk to take, well away from the nerve, well away from parathyroids, to get that prophylactic data, and only do a more traditional central neck from a prophylactic standpoint if I have a higher risk tumor. I can say that myself over the years, I have gotten more toward what Dr. Kazahaya and Bauer and do it at CHOP, and they're a little bit more proactive about true prophylactic central necks than I initially was. I've gone a little bit more in that direction, but I think we need to kind of think about and define and understand what a central neck dissection is, and is what some people are talking about, like kind of like what I'm describing as a mini central neck, where you just take some safe lymph nodes, or are we really cleaning it out in a prophylactic sense?
Yeah, I mean, I think that if you are just taking the convenient lymph nodes in the pretracheal region or prelaryngeal, that I'm not sure what the value added. I think a minimum number of lymph nodes has always been part of the discussion here, and it's varied from 5 on up as being legitimate. But all of us who are in this know that there is just a tremendous amount of variability with respect to the number of nodes that are actually present in some individuals, varying with the presence of coexisting thyroiditis, and also depending on the pathologist who is looking at a nodal sample and dissecting out and looking at and capturing all of the nodes that may be present. Andy, do you have any thoughts on what you consider to be perhaps an adequate number to be able to justify using that from a prognostic perspective?
I think the only data that's really been reasonable is from Julian Sosa, the retrospective data kind of correlating tumor size and number of lymph nodes. And I think 5 to 6 is probably an adequate sampling to at least have some idea of the accuracy of the sampling, to be able to use that information. And medically, I think it still comes back to, I'm not a surgeon, so it's easy for me to say to do a prophylactic central neck, but as the medical person, mostly in many centers, that person responsible for long-term surveillance and trying to reassure patients that we really have achieved remission, the lower risk, lower invasive, I think is easier to be reassured about. And I've been practicing, for long enough to be comfortable with these discussions. But for a classic PTC or some of the other variants, the more information we have, the higher even my own, comfort level is, that I know that we can achieve remission. And if, to your point, Mark, if they don't end up on levothyroxine after lobectomy, then how long are we going to surveil them for? And it's not about their outcome, right? The stage 2 is the most any pediatric patient could be as far as disease-specific mortality. It's about just comfort level and reassurance to the family, the patient, and the provider that the lobectomy was adequate. And I think there is more, we can be better selective about who would benefit from prophylactic central neck. If there's smooth margins on ultrasound, if they have a low invasive oncogene, I think those types of data are really important to explore and then to prospectively study. to try to even define who would potentially benefit from a prophylactic central neck, because I don't think every patient with Bethesda 5 or 6 would benefit. I think there's a way to even stratify that group of patients.
Interesting. Maybe this is coming at this really from my own naivety here. Could you just comment as to what the likelihood of a pediatric patient who undergoes a hemithyroidectomy will require thyroid supplementation? Is that different than in the adult world, which we usually quote 25%?
It's well, the one study that Ken Causal published from our group was about 85% do not need thyroid hormone replacement post-lobectomy. The group with the highest risk of needing it are patients with autonomous nodules, whether the contralateral lobe recovers. But the thyroid cancer patients that had normal status, no autoimmune thyroid disease, normal TSH preoperatively, 85% of them would not need thyroid hormone replacement. Then depending on, should we suppress them for a period of time if it was classic PTC? That's another discussion. Or should we be happy if their TSH is 2? And if I think it's a low risk patient, the purpose of doing lobectomy is not to put them on thyroid hormone. But again, that's another part of the discussion of what do we target the TSH post lobectomy for papillary thyroid cancer.
To be
I'd say that's mirrored my experience as well. I haven't specifically looked at the numbers, but yeah, way higher than the 25%, but yeah, closer to 80 to 90% sounds about right.
So it's actually the comparator is 75% versus 85%. 75%.
Oh, gotcha. Sorry, I thought you said.
Yeah.
So
So most patients don't, as long as you say a normal TSH is our target. Most patients don't need replacement.
Great. Unfortunately, we are up against the end of the hour here. I want to thank both of you and to thank our listeners. I feel like we've opened up a larger number of questions than we've answered here. Hopefully, the guidelines for pediatrics, when they come out, will have all the answers. So thank you both, and we invite everybody to come back next week and join us for our next version of Tyro MDS here. So thank you, and everybody stay safe.
Thanks, everyone.
Thank you.